to be to develop effective plans to overcome cultural specific barriers to screening your patient populations. Then we're going to also go over evaluating patient cases to identify when to screen patients and how to refer to a specialist, care for treatment. So I'm going to be showing 2 different videos, and there'll be a little bit of discussion with each one of those. And describe current treatment guidelines and newly available Hep B therapies. And then finally, to discuss the importance of early screening and treatment in specific populations, including pregnant and postpartum women. So we're going to start with our pre-assessment. So I think you have your ARS systems handy. The first one here is a 44-year-old man is born in Venezuela, presents for his first visit to your practice. Should you screen him for hepatitis B? 1, yes, all new patients should be screened. 2, only if the patient's history or records reveals Hep B risky behaviors. 3, yes, because he was born in Venezuela. And 4, no, because Venezuela is in South America, which has a low prevalence of Hep B infection. So make your answer choices. All right. 2 more seconds. All right, so we're going to come back to the responses to these questions a little bit later. Next question is, how confident are you in your ability to identify USPSTF-defined Hep B endemic areas to more effectively identify first and second generation immigrant populations who should be screened for hepatitis B? So 1, not confident, 2, somewhat confident, 3, neutral, 4, confident, 5, very confident. So select your answers. All right. And how confident are you in your ability to develop effective plans to overcome culture-specific barriers to screening your patient populations for Hep B? Make your answer choices using your ARS keypads.
I hope this old train breaks down, then I could take a walk around.
All right, on to the next. And how confident are you in your ability to determine when is the right time to refer your patients to specialist care for Hep B treatment? So make your answer choices using your ARS keypads. 1 is not confident, 2 somewhat confident, 3 neutral, 4 confident, 5 very confident. All right, how confident are you in your ability to describe current treatment guidelines and newly available hepatitis B therapies? Go ahead and use your keypads there. And how confident are you in your ability to discuss the importance of early hepatitis B screening and treatment in specific patient populations, including pregnant and postpartum women? Go ahead and select your answers.
Hey, where did we go? Days when the rains came down in the hollow, playing a new game, laughing and a running, hey, hey, skipping and a jumping.
All right, and which of the following is an appropriate method for to address Hep B screening concerns? Number 1, help patients understand that the primary route of transmission in endemic countries is mother to child. 2, advise patients that the U.S. federal government will not be informed of their hepatitis B status. 3, advise patients that although there are no currently highly effective treatments, new drugs are in the pipeline. Or 4, all of the above. Or 5, answer choices 1 and 2.
And as he grew, he'd say, I'm gonna be like you, Dad. You know I'm gonna be like you. And the cat's in the cradle and the silver spoon. Little boy blue and the man on the moon. When you're coming home, Dad, I don't know when, but we'll get together then.
All right, so we're going to come back to those responses, see how much we can move the needle and the confidence level at the end of this talk. So start with kind of who and how to screen. So actually one more question to start. According to the U.S. Preventative Services Task Force recommendations, patients born in all of the following regions except should be screened for hepatitis B. Number 1, Southeast Asia. 2, Africa. 3, Middle East. 4, Western Europe. 5, Eastern Europe.
And the cat's in the cradle and the silver spoon. Little boy blue and the man on the moon. When you're coming home, Dad, I don't know when, but we'll get together then. You know we'll have a good time then.
All right, so let's talk a little bit about the burden of hepatitis B infection and where we see it most commonly. So globally, we estimate that about 300 million persons are living with chronic hepatitis B infection, and over 780,000 deaths are attributed to hepatitis B-related causes every single year. It's actually the most common viral hepatitis infection worldwide, followed by hepatitis C, which has much less burden of infection. Now, what do we see here in the United States? We estimate that approximately up to 2.2 million persons are living with chronic hepatitis B infection. And I think the most important thing here is that actually we estimate about 50% or more have not yet been diagnosed with their infection and are unaware of their status. It's actually estimated that we've had 38,000 new cases of infection in 2009. And we estimate that deaths attributed to hepatitis-associated chronic liver disease, or HCC, annually is in the order of around 3,000 related to hepatitis B. So we think about kind of what's the geographic distribution of chronic hepatitis B infection worldwide. You can see that the map is kind of separated into areas of high prevalence in this green color. So that's greater than or equal to 8% of the population being infected with hepatitis B. Intermediate prevalence, which is that kind of deep blue color, where we estimate 2 to 7% of the patient the population in those countries are infected with hepatitis B. And then countries like the United States, where on the whole we estimate less than 2% of people are chronically infected, but I'll show you how that's kind of different here based on where people originate. So, we have actually millions of people who originate and immigrate to the United States, where the prevalence of Hep B is much higher. And in fact, over 60% of the close to 30 million immigrants who entered the United States between 1974 and 2008 were born in countries where they had either an intermediate or high prevalence of chronic hepatitis B. So when you look at the contribution, if you look at kind of all the persons with chronic Hep B, and we look at kind of what are the different kind of target populations to think about, foreign-born individuals make up close to 40%, 47 to 70%, of people who have chronic infection in this country. So really understanding the importance of, if you have a foreign-born person in your practice, understanding if they originate from an intermediate or high prevalence country is really important. And it's important because of this. United States Preventative Services Task Force recommends hepatitis B screening in the following individuals. So people born in regions where the prevalence of Hep B infection is really greater than or equal to 2%. So anybody who originates from an intermediate or high prevalence country. And they also recommend hepatitis B testing in US-born people not vaccinated as infants whose parents were born in regions with hepatitis B infection where the prevalence is high, greater than or equal to 8%. So high here, again, is highlighted in areas of red. So the most common patient populations we think about are those of East Asia, Southeast Asia, as well as West and Sub-Saharan Africa, and parts of northern parts of South America as well. So the USPSTF also recommends that we test the following individuals for hepatitis B in addition to the ones I just mentioned. Household and sexual contacts of persons infected with hepatitis B. So people infected with HIV, injection drug users, men who have sex with men, and people with certain medical conditions, including those who are immunosuppressed and those who are undergoing hemodialysis. So hepatitis B screening is also recommended in pregnant women. It should be performed in all pregnant women in this country. And knowing the status of hepatitis B in pregnant moms is really important in order to determine the risk of transmission mother to child, or what we call vertical transmission to the newborns. So depending on the different blood tests, serologies that we can check for hepatitis B, so these are all people who are infected with hep B have surface antigen as one of the serological markers. Now, if they also have E antigen that's positive, and the infant does not get a vaccine at birth, there's a greater than 90% risk of transmission from mom to baby at birth. That's very much in contrast to when we know the mom's status and we can offer vaccination and hepatitis B immunoglobulin to the infant at birth if the mom is positive for E antigen, in which the risk is substantially reduced to 10 to 15% vertical transmission. And for moms or pregnant women who are E antigen negative, the risk of transmission to the infant is much lower, but can be reduced from 5% to less than 1% with vaccination and immunoglobulin strategies. So why do we care about hepatitis B? Well, what we worry about is what the potential sequelae that can happen from having chronic infection, including end-stage liver disease, cirrhosis, which is our medical term for a lot of scarring in the liver, right? And risk of liver cancer, hepatocellular carcinoma. Worldwide, hepatitis B causes 50% of liver cancers that we see. And hep B is also our carcinogen that is second only to smoking, tobacco, in causing cancer deaths worldwide. And in large part, hepatitis B is what we call a silent killer. So the vast majority of people who are infected don't have any symptoms. And in fact, as I mentioned at the beginning of the talk, over half of the people in the United States who are infected have not yet been diagnosed. They can be asymptomatic until they develop liver failure or a very advanced liver cancer, which unfortunately is how a lot of patients do present by the time I'm seeing them as a hepatologist or in our liver transplant office. Oftentimes, if you just check their hepatic panel, that actually might be normal when you look at their AST, ALT, and other labs. And as many, again, of up to 2/3, but we estimate at least a half of people who are chronically infected are really unaware of their status or of their infection. Now, the age at which you acquire this infection really determines your risk for developing chronic infection. So worldwide, more than half of cases of hepatitis B infection are transmitted mother to child silently at birth. And when you acquire this infection at birth, over 90% of people will go on to have chronic infection. That's very different than when you acquire this or are infected as an adult, where you have a robust immune system in which you're able to, most often, more than likely than not, clear it on your own. It's about 15% or less of patients who are infected as an adult go on to develop chronic infection because they're not able to clear the virus. So you can tell that the age at which you acquire this infection really determines your risk for chronic infection. Now, what are the different ways in which a person can be infected with hepatitis B? Well, as we discussed, mother to child really takes up the shoulder of kind of how this is transmitted. You can get what we call horizontal, so within household during early childhood. The virus itself can survive for at least 7 days outside the body. So kind of in an intimate household contact, you can see how there's actually early childhood transmission as a risk as well. Healthcare professionals are also at risk, which is why we often during our employment screening time will be asked about our immunization history and status, and if that's known, they often will check you if you have direct patient care contact and recommend, if you haven't been vaccinated, to be vaccinated. And then certainly other traditional medicine might present risk factors, including things like scarification, acupuncture. And in non-endemic countries like the United States, where our prevalence overall is very low, less than 2%, the major way in which people acquire this infection is as an adult through unprotected sexual intercourse. So having unprotected sexual intercourse with a partner who has infection. And then injection drug use also makes up about 20% of the cases in countries like the United States here. So one question that often comes up is, what tests are you supposed to check for screening? And it can get a little bit confusing, but I think the thing that we really want you to go home with today are kind of the tests on the left here. So the hepatitis B surface antigen, that's the marker for infection. If that's positive, your patient has infection. Hepatitis B surface antibody is really a marker of immunity. And you can get it two ways, either through vaccination or because you had the infection and your immune system was able to clear it on its own. So having surface antibody is just really, again, a marker that you're immune to hepatitis B. Now, core antibody helps us really distinguish those patients who have had vaccines, and that's why they're immune, or they have had real infection, and that's why they're immune. Now, somebody who's surface antigen positive will often be core antibody positive. So again, think of it as just a marker for infection, past or present, okay? And the surface antibody and surface antigen then help you tell you who really has infection now and who's kind of cleared it. Now, if somebody is surface antigen positive for hepatitis B, the additional tests that we typically recommend are that E antigen. So I just mentioned that in the context of pregnant women. We check that often. E antibody, and then, of course, the hepatitis B viral load. And those things kind of help guide our decisions around who should be recommended for further evaluation and potentially treatment, in addition to some other factors that I'll share with you in a minute. So one question that often comes up is, how do you interpret all of these serologies? So I just kind of went through some of these, but we've included a little bit of a table on this slide to help make it a little bit easier for you to kind of think about it. So again, anybody who's got surface antigen that's positive has infection with hepatitis B. So that's the one thing to remember. And then you're immune if you have surface antibody. So this marker here, anti-HBs. If that's positive, you have immunity. If you have all three negative, you're certainly susceptible. It means you don't have immunity, you don't have infection. And then again, chronic infection, this is the one that you guys are going to see the most in practice, most likely. Again, look for the surface antigen to be positive. Sometimes you'll get a patient that says, "Doc, I came in, I had unprotected sexual intercourse. Can you check me for everything I might be at risk for? I don't know my partner's status." So, certainly you could consider either starting, if they don't have even any symptoms, with Hep B surface antigen, but the core IgM test is the test that would be positive in the acute setting. So, so those are the kind of take-home points. So those two slides would be helpful for you guys to interpret the serologies. So what are the clinician barriers to screening for hepatitis B? So, primary care doctors particularly, and physician assistants and nurse practitioners are really on the front line of screening, in addition to taking care of all of the other complaints that patients come and see primary care doctors for. So there's often this feeling of too many things to keep track of and accomplish in a very short time interval that we're expected to see patients, right? Your patient's coming in to see you because they either have a focused symptom or complaint, and then maybe the first time you're seeing them and you're trying to get everything done. So it's really hard to keep this at the front of your minds. The Hep B serologies, as I just went through, they're confusing. It's sometimes confusing to remember which ones to order and how to interpret it, and so that can lead to a feeling of, if I'm going to have trouble interpreting this, why should I order it for some providers? The Hep B guidelines they're conflicting and they're confusing. So knowing what to do with that information, even once you interpret the serologies to tell a patient, should they get treated for hepatitis B or not? And I think that's kind of really a decision point then, once you identify somebody who has surface antigen that's positive, to refer them to a specialist to kind of help you with co-managing that patient and making those determinations and discussions. And then we really don't have great reminders for all of the different things we're supposed to screen patients for in our practices. So what are some potential solutions for clinician barriers to hepatitis B screening? Certainly understanding what the risk factors are, making that risk assessment, and offering kind of screening as a routine part of your care. Understanding hepatitis B screening guidelines. So we just went over kind of who are the people to be thinking about for testing or offering for screening for hepatitis B. Thinking about ways to effectively engage patients around the discussion, right, of offering hepatitis B screening, because you do want to let them know why it's important to be tested, and I think that's what some of our videos are going to focus on next. And then learn how to screen them in terms of which tests to order in serologies and how to interpret those. Identifying opportunities for prevention. We do have highly effective vaccinations for hepatitis B. And then understanding when and how to refer those patients to co-manage those patients if they are infected for hepatitis B. So indications for referral and when to treat. So typically, from a primary care standpoint, referral to a specialist is really based on the primary care doctor's or physician or provider's comfort level. So all surface antigen positive patients, they are chronically infected and they should be managed by a specialist for hepatitis B. I practice in New York City where, for example, in a lot of the Chinese communities, for example, in downtown Chinatown and Manhattan, a lot of the primary care physicians, because they see it so frequently, their comfort level is very different than primary care providers in other communities or even outside of the city. So again, knowing what your comfort level is and knowing when to refer is really important. Hepatitis B treatment should be considered in what we call immune active chronic hep B patients, and I'm going to show you how that's defined. And patients who are not on treatment, so even if they're not recommended for treatment, they need to be monitored regularly with blood work, typically at a minimum every 6 months, and they may meet different criteria set forth by different groups, depending if you're African or East Asian, your age, your gender, for liver cancer screening with an ultrasound every 6 months. So even if you're not on treatment, there's the other part of this is screening for liver cancer. So what do you do in terms of, particularly as a specialist, when you have a patient who's got hep B? So typically we would start with a history and physical, a number of lab tests, including the hepatic panel, which I mentioned will sometimes be normal. We'll check specific serological and virological blood tests, so that DNA is the viral load level. We typically will get an ultrasound or some type of imaging at baseline. Now, we used to recommend liver biopsies in a lot of patients very early on just to see how much scarring is in the liver. So we rate scarring in the liver world usually on a scale of 0 to 4. So if somebody has scarring at a level of 2 or more, that's showing us that they have kind of progression of liver disease, and those patients are particularly at risk for developing liver cancer. Well, liver biopsies are invasive. They have risks. And we have now developed what we call non-invasive ways to measure the liver stiffness in the office. Those tests can take as short as 5 minutes. And a lot of times they use transient elastography, vibration methods, and using limited ultrasound to see kind of how stiff the liver is based on the vibration patterns when you create a sound wave right next to the right upper quadrant where the liver sits. The other things that we recommend to check include the subtype of hepatitis B that sometimes can portend cancer risk depending on the different subtype. We also look for other viruses, so we usually routinely check patients who are infected for HIV, make sure that they're not dual infected. For hepatitis C, some patients are actually, because of the shared routes of transmission, can have hepatitis B and hepatitis C. And then typically Delta virus is also another viral hepatitis that's checked in anybody who's infected with hepatitis B. So I wanted to now kind of go back, sharing that information that we've shared, to one of the questions we had a little bit earlier on. So according to the U.S. Preventive Services Task Force recommendations, patients born in the following region except should be screened for hepatitis B. So kind of thinking through what we just went through, select your answer choices using your ARS systems here.
Although now most of my days I spent alone, 1,000 miles from the place I was born.
Okay, so The green shows us the before, the first time we asked the question, and the red shows the after. So, Western Europe was the correct answer here. All right, so go to the next slide here. So now we're going to move over from talking about screening and who we should be targeting and how to do screening to really how do you offer screening in the office, so modeling your conversations for hepatitis B screening. So we're going to start with first patient video.
Luis Alvarez is a 44-year-old man who presents for a routine physical examination. He recently relocated for a job and changed healthcare providers. Today is his first visit to our practice, where I'm a PA. Luis arranged for his medical records to be transferred to the new practice. Luis was born in Venezuela and immigrated to the United States 15 years ago on a work visa. He married a U.S. citizen 8 years ago. Mr. Alvarez, nice to meet you. You're here today for an annual exam, is that correct?
Yes, I have a new job here.
Well, it looks like we have your records from your previous doctor. You were born in Venezuela, and you've lived in the U.S. for a while now?
Yes, that's right. I met my wife here.
And according to this, you were prescribed a medication for high blood pressure a few years ago. Do you still take it?
Yes, actually, I need a new prescription. That's one of the reasons why I'm here.
Can you tell me a bit about your lifestyle? What do you do for work?
I work for a trucking company. I started out as a driver when I came to the U.S. Now I work in operations.
And what do you do outside of work?
Me and my wife like to ride our bikes on the weekends to the lake, and I play in a soccer league with older guys like me.
Okay. Well, any other issues aside from the high blood pressure?
Not really. My knees sometimes hurt when I play in tournaments.
All right. Well, everything else looks fine. I'll just do a quick physical exam, and we'll draw some blood for routine tests, and then I'll take care of that prescription.
Thank you very much.
Okay.
All right, so keeping in mind, this is a talk on hepatitis B. Why was this not an optimal visit? What things can you think about? And we'll open this up to audience participation here. I'm hearing some whispering. Okay, didn't take a full history, including surgical history, medical history, family history, social history, right? So I think there were pieces of the history missing. What else? Vaccination history, right? I think at the beginning they said there were some records transferred over, but we don't have any discussion of reviewing those records and saying what things might still be outstanding. Yeah, so going through what blood tests are part of the routine blood tests that you'd be offering for this patient. All right, so now I think we're going to show this video now optimized.
All right. Well, everything else looks fine. You were born in Venezuela and you've lived in the U.S. for a while now?
Yes, I met my wife here.
Well, one other item we review with all new patients is their immunization history. And according to your records, you've never been screened or immunized for hepatitis B. Is that correct?
I am not sure. What is this?
It's a virus that can cause liver disease if it's not treated. You may have heard it called HBV for hepatitis B virus.
Oh, I may have heard of it, yes, but there's no need. My wife and I are very healthy.
I understand. I'm glad you're both well. But the reason I bring it up is that HBV is very common in certain parts of the world, such as Venezuela. So it's possible you may have been exposed to the virus before you came to the U.S. The Centers for Disease Control and Prevention recommend one-time screening of all people who emigrate from regions where hepatitis B is common.
But wouldn't I feel sick? How do you get it?
Well, the virus spreads through body fluids like blood or semen. Outside the U.S., the most common way it's transmitted is silently from mother to child during pregnancy or birth. Someone who's infected with HBV can remain well for many years, but if it remains untreated, it can cause liver damage and even cancer.
From my mother? No, I don't want to be tested. People might look down on my family, and I would think this is a disgrace. And you said this is from the government? I don't want the government involved.
Well, the health department does recommend screening, but that's all. The test is confidential. Neither the government nor anyone else will know the result except us. And please understand, anyone can have HPV. There's no shame in it.
Do you ask your other Hispanic patients about this? Your other patients?
Well, it's not about race or ethnicity. It's only about being born in a region where HPV is common. It happens that HPV is common in parts of South America. It's also common in parts of Asia, Africa, and Eastern Europe.
I guess. I don't know how I would talk to my wife and my mother about this.
Well, that's something we can discuss if it's necessary. Maybe a first step would be to order the blood test. But as I said, you seem to be in very good health.
Okay, thank you.
All right, so we try to put as many of the potential things that might be raised in a discussion when you're offering this to patients and going through why it's important. So we think about patient barriers. Again, explaining and identifying endemic areas in terms of who we should be targeting in our patient populations or practices. Lack of understanding of why it's important to do the screening and how it can be transmitted. It's such a common thing for actually me as a hepatologist to actually experience this issue of cultural shame when you're talking about offering of these tests. Privacy, so who do these test results get disclosed to? So the one caveat I'll share here is that in many states, such as New York, it is reportable to your local state health government or city health government. And it varies by state to state in terms of what the requirements are for acute, chronic, and both. And then really addressing cultural barriers to screening, so trying to put them at ease, explain to them why it's really important to do this testing and what could be the value of offering this test. Mentioning that there's highly effective vaccines and highly effective treatments as part of that conversation is important, and really stressing that they don't have to have any symptoms, which is why we really need to do a good job of offering the test to people at risk. All right, so now we're going to give you our second kind of video here. Go ahead and play it.
Yu Wen Lee is a 28-year-old woman who presents for a family planning visit. Yu Wen was born in the United States to parents who immigrated to the U.S. from Taiwan 30 years ago. She has no significant medical history. Hello, Miss Lee. I understand you're interested in becoming pregnant.
Yes, my husband and I have been talking about it for a while, and we think it's time. My parents will be so excited.
Have you told them yet?
Not yet, no. I wanted to talk to you first. I wanted to know what to expect before we started telling people.
Okay, well, this is a good place to start. There are a few tests we can consider, and we'll talk about your lifestyle habits and your health history.
Okay.
I see in your records that you received most of the recommended vaccines, and you were born in the U.S.?
Yes, my parents are from Taiwan, but they came to the U.S. before I was born.
Any family history of illness?
I don't think so. My dad takes medication for cholesterol, but he and mom are fine. And I'm my only child. I did have an aunt who died a couple years ago in Taiwan. They said it was liver cancer, but I didn't know her very well.
Okay, let me ask, have you ever heard of hepatitis B?
I've heard of hepatitis.
Well, hepatitis B is a virus. It can cause liver disease and liver cancer if it's not treated. The reason I ask is that hepatitis B is common in certain regions of the world. Taiwan is one of those areas.
Do you think that's what my aunt had?
Well, it's possible, but I couldn't say for sure. But we should definitely screen you for hepatitis B since your parents were born in Taiwan. National guidelines recommend a one-time screening of people born in countries with a high amount of hepatitis B. And that extends to children born in the U.S. to parents from those countries.
Oh, really? How's it transmitted? Can it harm my baby?
It can be transmitted through body fluids like blood or semen. For example, it can be transmitted through sexual contacts or injection drug use. And it can also be transmitted from mother to child during pregnancy or birth.
No, my mom and dad met in high school. There's no way they got a sexually transmitted disease. And I married my first serious boyfriend. No one in my family has ever used drugs. This can't apply to us.
Okay, let's just go ahead with the rest of the exam for now. Okay.
All right. Okay. So why was this first case scenario not an optimal visit? Some things were obvious, but hearing a little bit of chatter. Any volunteers? Yeah, so going through, I don't know who mentioned it, sexual, so getting a full history, although she's kind of, in terms of how the conversation was going about not having any risk factors and, not wanting to feel potentially stigmatized in terms of how this test was being discussed. So obtaining a full history is always very important. What else? Yeah, to work with the patient to try to engage them a little bit more, right? It's definitely every patient's right to say that they, in the end, don't want to have something done. But our job is to try to really impress upon them why it's important to offer these things and understand what potential risks might be by not doing the tests. Anything else? I think those were the big ones. And yes, certainly given the country of origin of the parents, that's why this was an important thing, and the history of the grandparent. All right, so now we're going to watch the video optimized.
Let's just go ahead with the rest of the exam for now.
Do you think that's what my aunt had?
All I would say is that your aunt's history raises my level of concern. I recommend testing you for hepatitis B because your parents are from Taiwan and also because you're considering becoming pregnant. The Centers for Disease Control and Prevention recommend a one-time screening of people born in countries with a high amount of hepatitis B, like Taiwan. And that extends to children born in the U.S. to parents from those countries, like yourself. It's especially important for you because one of the main ways hepatitis B is transmitted is from mother to child during pregnancy or birth.
You mean I could have gotten it from my mom without knowing it, and I could pass it on to my baby?
That's correct. Outside the U.S., mother-to-child transmission is the main route of transmission for hepatitis B.
But none of us are sick. I mean, my aunt died. Shouldn't we be sick?
People who have hepatitis B can seem fine for many years before they start to show symptoms. It's often silent. We want to treat anyone who's infected before they get sick, and also to prevent them from giving it to someone else.
I get it. I guess that's okay.
If the test comes back positive, which is unlikely, we can talk about how you can discuss this with your parents.
Oh, it sounds a little scary.
Well, getting tested is the right thing to do, and it's a treatable disease. For now, we want to ensure that you have a safe pregnancy and a healthy baby.
All right, thank you.
All right, so that was the optimized version of the video. So thinking again here, patient barriers that kind of came up. So stigma, various cultural communities might attribute this to sexual promiscuity or other risk factors that get discussed, such as injection drug use, lack of understanding. So again, thinking about how to frame the conversations around screening and modes of transmission. Modeling effective conversations around screening is really important, which is why we're spending time in this portion of the talk. And in that modeling, we can really help patients by destigmatizing hepatitis B and really trying to identify and address cultural barriers that might come up to offering testing, talking about the value of screening again and potential treatment, discussing prenatal and postpartum management, and again, impressing upon patients that this is an asymptomatic disease. So thinking again a little bit further in terms of how to effectively engage patients. So again, providing that context for why offering this screening test is important. So getting a really full history, heard that on both cases. So eliciting that family history, identifying any additional risk factors, discuss the risk of co-infection, which wasn't really part of the conversations here, but certainly in people who are positive, and then obtaining alcohol use and sexual history, and counsel cessation abstinence, particularly in those who test positive, and explaining what it means to have Hep B infection. So this is once you've offered the test, and for the people who come back positive, letting them know that there's a risk of liver cancer, and highlighting ways in which we have really effective treatments for hepatitis B, and if they're negative, highly effective vaccines to prevent it, and modes of transmission to see how we can prevent transmission from occurring by testing partners and offering vaccines if they're not immune already. And then highlighting that there, again, are effective treatments to really decrease the risk of long-term sequelae or bad outcomes. So possible solutions for patient barriers. Other things that sometimes come up, and we've included this slide as well, a lot of times some of our patients may not have insurance, so how do you get testing to be covered? So patients will often say they don't want to get tested if they're going to get billed, particularly those without insurance. So this varies state to state, community to community, but reaching out to kind of your public health department to see if there are any resources in the area for free testing is something that you can often do. Some public health departments actually have gratis vaccination programs where patients can come into testing or vaccination centers that they run to offer actually free vaccines. Again, and this varies, so you'd have to reach out. And then providing appropriate patient education materials can be done. There are a number of materials translated into multiple languages, because again, this is a disease that primarily affects foreign-born populations. So the CDC and others have translated a number of education materials around screening and infection that are available online. And we also have developed a Scale Hepatitis B app, which kind of helps you look based on zip code, city, or state for specialists that you could refer patients to. So encourage you to think about downloading that if this is something that's relative to your practice. It also includes counseling tips and the CDC screening recommendations if you need like a quick reference, and links to additional patient education. It's available in the App Store, on iTunes, Google Play, and Amazon. All right, so which of the following is an appropriate method to address hepatitis B screening concerns? Number one, help patients understand that the primary route of transmission in endemic countries is mother to child. Number two, advise patients that the US federal government will not be informed of their hepatitis B status. Three, advise patients that although there are no current highly effective treatments, new drugs are in the pipeline. Four, all of the above, or five, one, and two. So we're asking this question for the second time to see if the information we provided changes your response. So using your ARS keypads, please select your responses.
Triumphantly, won't you help to sing these songs of freedom? 'Cause all I ever have, redemption.
Okay, so one and two. So as I mentioned, U.S. federal government is what we were getting at in that question. Some patients, and when we do this in the community as community-based screening in New York City, we'll ask questions such as, can they be deported? Sometimes they've heard of stories of people being deported. So again, like reassuring them kind of who the results are really kind of disclosed to, and that it can't be used in those kind of ways are important. All right, some more people answer that one correctly after. So let's move on to determining initial treatment and individualizing therapy. And again, I think this is something that will more likely happen in the context of working with a specialist. So this is really targeted to those who have hepatitis B. Maybe you've identified them or they've come to you with already a diagnosis of hepatitis B. So we'll start out with a question using your ARS keypad responses again. Which of the following is not true about tenofovir alafenamide? TAF is the name we give it. It's a prodrug of tenofovir. Number two, it has improved renal safety profile compared to tenofovir. Number three, it has decreased plasma stability compared to tenofovir. Four, it has less bone toxicity compared to tenofovir. So we're going to talk just a little bit about shared decision making. So the management and treatment options, whenever we're discussing kind of in patients who are infected, really need to be in conjunction, really this shared kind of conversation with the patient about kind of what we recommend based on the best data that we have, that the guidelines have put forth, and then tailoring that really to where the patient is with respect to, if they're accepting, if they are recommended for treatment, do they want to start antiviral treatment? If they're not recommended for treatment and they want to start antiviral treatment, kind of coming to really a shared decision with the patient about how to proceed or manage them. The AASLD is the National Liver Organization. They've put out practice guidelines that get updated every couple of years, and those can be used to help guide those discussions regarding who's at risk of disease progression, why treatment would be recommended for one patient with specific disease characteristics and not necessarily for another patient based on their disease characteristics. And then really the patient opinion should be factored into decisions regarding management and treatment. And I'll say this is particularly true when we're talking about pregnant women who are identified as having infection. People have very clear opinions often on whether or not they want to take any antivirals during treatment. And so discussing it and coming to kind of a decision together is really important in building a relationship. So the life cycle of hepatitis B is very different than other viral hepatitis. It actually incorporates into the host DNA of a person who's infected. And that's why there's no current curative therapies for hepatitis B. But I'll tell you a little bit about kind of how this landscape's changing. So again, who's recommended for treatment? We talked a little bit about people who, based on a biopsy or that non-invasive ways that we can measure whether or not they have stage 2 scarring or more, would be recommended. But other people who are recommended based on the hepatitis B viral level, right, in conjunction with knowing some of the other serology tests we check in the blood. So using different cutoffs depending on those serologies. Whether or not they have an ALT test in your hepatic panel, right, that's 2 times the upper limit of normal. Actually, what's really normal for a woman in terms of an ALT is 19, even though our assays oftentimes go up to 40 or 50. And for a man, it's 30 or under is a truly normal ALT. And then, again, the evidence of stage 2 scarring or more. So how do we treat hepatitis B? Well, with antiviral treatment, which can kind of be categorized into nucleoside analogs, nucleotide analogs, and immune modulators. Now, the ones that we talked about in that question were tenofovir alafetamine, or TAF, or tenofovir. And TAF is the one that's been most recently approved in November of last year, and we'll talk a little bit about how that's different. So the goals of treatment for currently approved treatments for chronic hepatitis B is 1, to reduce the risk of long-term clinical bad outcomes, so reduce the risk of liver cancer, reduce the chances of developing cirrhosis. And there are different markers of treatment response that we look for. So the number one thing we often look at is the virus level. So the whole goal of treatment is to suppress the virus. So what we typically do in the patients who are on antiviral therapy is really look for that viral load to be undetectable if they're recommended for treatment. So that's what we're checking every 6 months or so at least to see if the treatment is working. We're also looking for whether or not, if the ALT was elevated, whether or not it comes down to normal. If like the viral load goes down to undetectable and the ALT stays elevated, that sometimes to us is telling us there could be something else going on in the liver. So again, making sure you've checked your hepatitis C, your HIV, all the other things that can impact the liver tests. And then the other kind of hallmark we look for is whether or not you can lose E antigen, and that's what we call seroconversion, and that can sometimes be used to guide whether or not to offer stopping antiviral treatment in some patients who are lucky to lose this infectious marker. And then certainly in patients who are immunosuppressed, we have like patients who are undergoing chemotherapy or immune modulator therapy, who there are guidelines kind of to recommend who should, while they're getting that chemotherapy, be prophylaxed against hepatitis B because of reactivation risks. And then prevention of mother-to-child transmission in certain patients by offering the infants immunoglobulin and vaccination at the time of birth. Okay, so the therapies for patients who are co-infected for hepatitis B and HIV, treatment of Hep B really needs to be coordinated in these patients with their HIV specialist, because a number of hepatitis B drugs, antiviral drugs, also have HIV drugs. So if you're co-infected, you can't just go starting treatment on the hepatitis B without considering what you're doing with the HIV, because you can really confer resistance and other things from the HIV standpoint. Now, Hep B HIV co-infection, most HIV-infected patients with Hep B get treated for their Hep B irrespective of those guidelines I talked about oftentimes. The ultimate choice really depends on a patient and the provider, but usually includes a tenofovir M-tricytidine containing backbone. And certainly the presence of Delta virus may influence treatment decisions. And then prior exposure to an antiviral treatment that's a little bit older called lamivudine for HIV treatment should also be considered because of baseline hepatitis B resistance in these patients. So now I mentioned a little bit, one of those drugs, the newest antiviral drug that was approved in November of last year called TAF, or tenofovir alafetamide. It's basically a prodrug of tenofovir, and compared to tenofovir, it enables better delivery of the actual active medication into the liver cells where the Hep B resides. And this is attributed to improved stability in the plasma and better activation mechanisms compared to tenofovir. It also has improved kidney safety profile and bone turnover parameters compared to tenofovir. So that was kind of one of the questions we went through. And then kind of what else is on the horizon in terms of treatment? So I probably 10 years ago, I wouldn't have been able to sit here and say that we really we're going to see us be able to achieve a cure, but we're actually at the point where we're now starting to look at developing curative therapies for hepatitis B. So rather than committing patients who we recommend for treatment for a lifelong treatment, right, because that's what the majority of them end up having to do, we're now looking at developing treatments that would offer a cure and really potentially revolutionize how we treat patients with hepatitis B. The mechanisms by which these new agents are being studied include kind of overwhelming the immune system and then really trying to clear the cccDNA, so how it gets integrated into the host DNA. This is kind of like the landscape of drug discovery for hepatitis B right now. So again, targeting that covalently closed DNA, or in the DNA that gets the part of the virus that gets integrated into the host DNA, immunomodulation therapy, interfering with RNA, targeting the surface antigen, that's the marker for chronic infection, looking at new polymerase inhibitors, and other agents as well. So the other part of all of this is certainly vaccination for hepatitis B. So here are the schedules. If you're just offering Hep B alone, the standard schedule is a 3-dose schedule at 0, 1, and between 6 and 12 for the 3rd dose. You can also offer A and B combined, usually on a 0, 1, 6-month dose. All right, so let's come back to that question. Which of the following is not true about this newer agent, tenofovir alafetamide, TAF? It's a prodrug of tenofovir. Number 2, has improved renal safety profile compared to tenofovir, has decreased plasma stability compared to tenofovir, it has less bone toxicity compared to tenofovir. So make your choices using your ARS keypad.
Deep down in Louisiana, close to New Orleans, way back up in the woods among the evergreens, there stood a log cabin made of earth and wood, where lived a country boy named Johnny B. Good, who never ever learned to read or write so well, but he could play a guitar just like a ringing a bell. Go, go! Go, Johnny, go, go!
All right, yeah, so it's not decreased, it has actually increased plasma stability compared to tenofovir. Great job. All right, so the key takeaways we're hoping you go away with today is understanding that Hep B represents a major public health problem, and it's underdiagnosed in the United States, and it disproportionately affects foreign-born persons that we are likely to see in our practices. Hep B screening is vital in specific patient populations, including pregnant and postpartum women. Thinking about effective specific cultural stigma conversations can lead to increased patient acceptance for testing or screening. Vaccines and therapies for hepatitis B are highly effective, and new therapies for hepatitis B infection that offer a cure are on the horizon. So we're going to end with the post-assessment here. So go back to our very first question at the beginning of the talk. We're at the end here. So a 44-year-old man born in Venezuela presents for his first visit to your practice. Should you screen him for hepatitis B? 1, yes, all new patients should be screened. 2, only if the patient's history of records reveals Hep B risky behavior. 3, yes, because he was born in Venezuela. 4, no, because Venezuela is in South America, which has a low prevalence of Hep B infection. So go ahead and enter your keypad responses.
Neath the halo of a street lamp, I turn my collar to the cold and damp.
All right, so yes, we really moved the needle. At the end of the talk, the right answer is the third answer choice, yes, because it was born in Venezuela, not yes, because all new patients should be screened. Okay, and this is a question really relevant to you and your practices. How many foreign-born patients do you see each week from Asia, Africa, the Middle East, Eastern Europe, and Northern South America, if you had to estimate? Less than 10, number one, 10 to 20 patients, number three, greater than 20 patients.
We'll go rockin' Robin, 'cause we're really gonna rock tonight. We rock, every little swallow, every chickadee, every little bird in the tall oak tree. The wise old owl, the big black crow.
All right, so almost like one third here. It seems like a relevant topic for many of you guys based on your practices. And how confident are you now in your ability to identify USPSTF defined Hep B endemic areas to more effectively identify first and second generation immigrant populations who should be tested or screened for hepatitis B? So select your answer choices.
A pretty little raven at the bird bandstand. Taught them how to do the bop and it was grand. They started going steady and bless my soul. He out popped the buzzard and the Oreo. He rocks in the treetop all
right.
day long.
So yes, we moved the confidence bars in the red towards the end of the talk. That's great. Okay, how confident are you now in your ability to develop effective plans to overcome culture-specific barriers to screening your patient populations for Hep B? Select your answer choices.
Night breezes seem to whisper, I love you. Birds singing in the sycamore tree. Dream a little dream of me.
All right. Okay, confidence level went up to more the confident and very confident. And next one. How confident are you now in your ability to determine when to refer patients to specialist care for Hep B treatment?
My house in Budapest, my hidden treasure chest, golden grand piano, my beauty focused EOU. Ooh, you.
Okay, so more confidence here at the end of the talk. And how confident are you now in your ability to describe current treatment guidelines and newly available Hep B therapies?
Over you. Ooh, you. Ooh, I divido. Give me one good reason why I should never make a change. Baby, if you owe me, then all of this.
I think it's your phone.
Oh, no, it's not my phone.
No?
No, my phone's not buzzing, it's off.
Okay.
Okay, and confident takes the day there. And then how confident are you now in your ability to discuss the importance of early Hep B screening and treatment in specific patient populations, including pregnant and postpartum women?
Think it's time for a change. You may get disgusted, start thinking that I'm strange. And kids are going to ground.
All right, more people are confident and very confident at the end of the talk here. And I think that was it. We'll open it up to questions and answers.
So, question from home. Is it possible for the mother to pass on the virus at birth and the offspring not to develop primary liver at age 42, yet be negative for HBV? Yeah, I get that.
Can you read that one more time?
So is it possible for the mother to
Okay.
pass on the virus at birth
Uh-huh.
and the offspring not to develop primary liver? Doesn't say anything after primary liver, but I'm thinking it's primary liver disease
Okay.
at age 42,
So,
yet be negative for HBV.
so about 10%, remember we talked about at the beginning, of the E antigen positive women who we're particularly more concerned about transmission from mother to child, especially if the baby doesn't get vaccination in HBIG. So there are certainly women who are surface antigen positive, E antigen positive, and get very lucky and don't transmit the virus to the baby at birth. So that's why we now recommend screening all pregnant moms, pregnant women for hepatitis B infection, so that we know that if they are infected, we offer vaccine and immunoglobulin to the babies at birth. All babies are recommended, according to the American Pediatric Association, to be tested or vaccinated for hepatitis B within 24 hours of their birth. And we know that we're not doing a very good job of this. The CDC actually just put out their viral hepatitis report, where this is one of the indicators that they're following. And this really unnecessarily puts children kind of at a vulnerable kind of status in terms of being able to acquire this infection when we have highly effective vaccines.
How much does it cost to do HBV screening at this time?
So that's a good question. Right now, most labs, like the lab at my hospital, can charge as low as $17 for a test for hepatitis B. And so, when we run my community outreach program, we actually do the testing, and it's run at our clinical labs in-house. We do combined hepatitis C and B testing, for example. We get both tests and an ALT for $34. Yeah.
If an infant from another country, I think this is a Thailand ISHEV positive?
One more time?
Thailand ISHEV positive. What is his risk of liver cancer? He remains HEV positive. What follow-up is recommended?
So the patient has hepatitis B?
It says HEV, so I'm thinking.
HEV.
Yeah.
So hepatitis E, certainly we see, and we are now identifying it more as a potential risk factor in certain patients for chronic infection and chronic liver disease. So in somebody who comes to your office with raised liver tests, and you check kind of the most common things, right? You're going through their medication history, you're checking hepatitis A, B, and C. The other thing, if you've excluded other things, and particularly when they're being referred to a specialist to try to help work this up, one of the things we'll check is usually hepatitis E. And hepatitis E can cause chronic liver disease. It can cause advanced, fibrosis in some patients. It's pretty atypical. We can do the serological testing. The viral load testing actually has to get sent to the CDC to be done. So usually you're doing that in conjunction with the hepatologist.
Is it possible to have PSC and not be positive for any hepatitis?
PSC. PSC or PSE?
I think they're looking at PSE.
So in my world, PSC stands for portosystemic encephalopathy. I'm not sure if that's what they were referring to, which is a stigmata of portal hypertension or cirrhosis. Anybody else have
For PSC?
another?
Yeah.
For PSE. Anything else that
No.
I'm missing in the
Or
primary care?
PSC?
PSC is primary sclerosing cholangitis.
Okay.
Yeah.
And not be positive for any hepatitis?
Yes, absolutely. So that's an independently
Okay.
a bile duct disorder, that can also cause advanced liver disease.
Okay, one final. If an Asian-born individual, lady, female, in the United States had received Hep B vaccine, how would you modify your counseling?
Counseling for offering the test?
Correct. Had
So-
received Hep B vaccine.
So I'll say this, about 15%, particularly in foreign-born communities, based on studies that have been published, sometimes get inappropriately vaccinated without ever getting tested. So if in doubt, and certainly, again, by the time they're seeing me as a hepatologist, for example, I often will just send the serologies to confirm, do they really have immunity, right? If they have immunity, their surface antibody should be positive, either through a vaccine or prior infection. But I would say about 15% of people get vaccinated when they originate from, again, a part of the world where there's more hepatitis B infection than here, and they get offered a vaccine without testing the surface antigen, and they think they're immune and they're actually chronically infected. The vaccine has no role for somebody who's got chronically infected, trying to get them to clear the virus. So there's no role for offering vaccines to somebody who has chronic infection.
Okay.
I think there was a question
We'll
here.
take one final question right here at the front.
You may have already partially answered the question, but I work in pediatrics, and we see numerous kids coming in, foreign-born, South America, Eastern Europe, Africa, Caribbean,
Yeah.
and we don't even consider doing any lab testing whatsoever. They just get their Hep Bs to get for the Department of Ed requirements.
Sure.
And do you know if that's appropriate, or what do the city health centers do prior to vaccination, if anything?
So are you talking about for screening or for managed, like people who you know have hepatitis B from a pediatric standpoint?
We don't know.
Okay, in terms of testing. So there are no screening guidelines or recommendations for non-adult patients, so for pediatric patients. The only caveats to that I can think of are certainly HIV-infected children often will get screened for hepatitis C and hepatitis B, depending on what their potential risk factors were for HIV. But still, there isn't any formal screening guidelines around testing for hepatitis B in the pediatric patient population. Yeah.
Well, we don't even test for HIV until they're 13 and above.
Yeah. It would be more if you knew you had a patient who was vertically transmitted, for example, from mom to child with HIV. Those are the scenarios in which we see those dual infections at a very young age.
All right. Join me in thanking Dr. Pani for an excellent
thank you.
presentation today. She is available for those of you that may have a couple of further questions for her. She is available at the back if you would like, and outside, to ask her any further questions. And we are almost there at the end. And at the end for you today, we have ADHD, making a difference in ADHD, screening and treating for primary care. Our speaker for this topic is Dr. Michael Feld.